this video, we'll discuss about nephrotic syndrome, which is one of the most commonly asked questions in exams and is often a topic which is mostly confusing. So, first of all, the definition. So, in nephrotic syndrome, what we get to see is there is massive proteinuria, that is mainly of albumin, more than 3.5 grams per day. Okay, so massive proteinuria of more than 3.5 grams per day, mainly of albumin. So there is a reduced albumin concentration. Now, the constituents of nephrotic syndrome, since it is a syndrome, so it is going to have the symptoms, group of symptoms. So to remember the constituents, suppose there is a person who has a nickname as Triple H, okay, and that person got promoted to 11th and took non-medical, so PCM, okay. So the person is Triple H and he took PCM, okay. So from H we have hypertension, then by H we have hypoalbuminemia, then we have hyperlipidemia and lipiduria. By P we have pitting edema and puffiness of face. By C we have coagulopathy. By M we have massive proteinuria. Okay. Now coming on to the etiopathogenesis. So for etiopathogenesis, first remember all the constituents properly. Now in etiopathogenesis, an inciting event occurs. It leads to glomerular injury. Now there will be an increased urinary loss of protein, and there will be decreased hepatic synthesis of protein, okay. So this is going to lead to hypoalbuminemia, okay. Now this will further lead to three things. There will be decreased oncotic pressure, which will lead to edema, okay. Then there will be urinary loss of antithrombin 3, reduced levels of serum protein SC, hyperfibrinogenemia, and there will be an increased synthesis of LDL and cholesterol, okay. So this is going to lead to, first this will lead to hyperlipidemia and lipiduria. This is going to lead to coagulopathy. This all will lead to nephrotic syndrome, okay. This is the pathogenesis of nephrotic syndrome. Now coming on to the causes. For causes, there is a primary and there is a secondary. For primary glomerular disease, as I told earlier, remember 4 or 3 M's and 1 F, okay. So minimal change disease, membranous glomerulonephritis, membranoproliferative glomerulonephritis, mesangioglomerulonephritis, and by F, remember focal glomerulosclerosis. Now for the secondary, this is mainly occurring due to some secondary manifestations to some other diseases. So for this, what you will remember is there is a person named as Sid and he works in an MNC, okay. There's a person named Sid and he works in an MNC, okay. So by SID, okay, by S we have systemic diseases. In systemic diseases, you will mention SLE, vasculitis, amyloidosis. By I, you have infection. So secondary syphilis, malaria, lepromatous, leprosy, post-streptococcal endocarditis. Okay, but then by D you have drugs. In drugs, gold, mercury, then penicillinamide, and a very important captopril. Okay, now by M you will have to remember miscellaneous. So toxemia of pregnancy and renovascular hypertension. Okay, then by N you will remember neoplasms, Wilms tumor in children, Hodgkin lymphoma, non-Hodgkin lymphoma, leukemia. Then by C you can remember congenital, the same uh, congenital nephrotic syndrome and Alpert syndrome. Okay, now coming on to the clinical features. The earliest sign of nephrotic syndrome is the puffiness of face and periorbital edema. Puffiness of face and periorbital edema. There is generalized anasarca. There is impaired immunity. There is coagulopathy. There is cough, dyspnea, ascites. Okay. Then coming on to the investigations. In investigations, there is a very important point to remember. In earlier diseases, we saw that we were seeing some broad cell cast in urine, but here, what you will remember is you do not see like the broad cell cast are not very common, but what is common is some oval fat bodies which are seen in the form of clusters of grapes. Okay, then you will have a 24-hour urine test in which you will see that the proteinuria is more than 3.5 milligrams per day. Then serum lipids, they will be increased. Then serum proteins, there is decrease. Then renal function test will come to be normal. The size of kidney by ultrasound, small, large in polycystic or amyloid kidneys. Then renal biopsy. Other tests also you can do, like serum complement levels, ANA levels, okay, urine electrophoresis, right? So now coming on to the treatment. For the treatment, first of all, we will treat the underlying cause, whether it is primary or secondary. Then the first manifestation was edema, right? So to resolve the edema, we will give a low sodium diet, and then we must give good amount of protein. Now for mild, moderate, and severe. In mild, we will give diuretics like furosemide, 80 to 120 milligram daily, tall butamide, 20 to 40 milligram daily. In this, we will combine spironolactone, which we will give 100 to 200 milligram. In severe, we will combine all of them with metalozone. Now, in desperate cases, there is salt-free albumin which is given. In proteinuria, we will give ACE inhibitors, ARB, NSAIDs. For hyperlipidemia, we will we will give atorvastatin, corticosteroids like prednisolone, infection control, coagulation, anticoagulation, then treatment of underlying cause.